question, but he will tell us the other view of the matter.
Good morning, and thank you so much for the invitation to be with you. In the matter of fact, it's good to hear about pelvic congestion syndrome from the other side of the coin. For me, hearing about it from the vascular point of view, and for you to hear it from me from the gynecological point of view. So, as you see, if you've been diagnosed with pelvic congestion syndrome, what do you need to know? First of all, I'd like to share with you this slide about the holistic medicine. Any patient with chronic pain has to be treated as a whole person, body, mind, spirit, emotions. Every part of that, if improved, will improve the pain of the patient. It's not only medication, not only surgery. We have to be very cautious when dealing with patients with chronic pain regarding the emotions and the spirit and everything. Chronic pelvic pain is actually a prevalent condition. It's not rare, but sometimes it's not said by the patient or not explored by doctors. It's as common as back pain and more common than bronchial asthma, so it's very common. And it's not only a medical condition, it also carries a heavy economic and social burden on the outpatient medical costs and the patients that do not go to work because of their pain during especially their menses. The congestion is the presence of enlarged venous plexuses of the productive tissues with impaired circulation and drainage. Many people worked on that, and finally you can say that it's a vascular disease with gynecological symptoms to summarize this condition. From the gynecological point of view, it's an anatomic dysfunction. The pelvic veins become more engorged and the capacity increases by 60%. With the kinking of the malpositioned uterus during pregnancy. With every pregnancy, the capacity of the veins increased. They do not go back to normal after the perpurium. So one pregnancy following the other, the condition ends with the pelvic varicosis that we see. This is also helped by sometimes by retroversion of the uterus. It's the same condition as varicose veins, but in the pelvis. Orgasmic dysfunction patients that do not reach the orgasm, they reach the plateau, so the veins are engorged, but they not reach the orgasm so that they enter the resolution phase. Sometimes this happens in external ejaculation, sometimes it happens because of patients fearing of getting pregnant. So orgasmic dysfunction is a cause of pelvic congestion syndrome. The disease is a psychosomatic disease, and this is why we say it is a chicken or the chicken egg. Does emotional characters having psychiatric disturbances are more liable to get pelvic congestion, or does the chronic pelvic pain turn these patients into psychological patients or psychosomatic patients? Sometimes we have hormonal dysfunction. The hormonal dysfunction is evident because when we use pills and things to suppress the ovulation, the patients are relieved from the pain. Also, doctors like us, like me, add to the situation by doing sometimes tumor ligation and putting IUDs into females. This increases the pelvic congestion syndrome. Endometriosis, multiple pelvic surgeries, having ovarian cysts, having fibroids, all of these adds to the condition. The pathophysiology, as you heard, is not only enlarged veins, but retarded flow inside the pelvic veins, as you can see in these two images. The patient usually has pain. The pain might be dull aching, one side progenating, low back ache, dyspareunia, postcoital bleed, aching, deep dyspareunia, chronic visceral pain, any type of pain. And she might have also menstrual disorders, menorrhagia, endometrorrhagia, intermenstrual bleeding, GIT and urinary symptoms, psychiatric disturbance. All this is associated with pelvic congestion syndrome. While examining this patient, you have to be very careful. You have to give the patient time. You have to make her feel that she can tell her story. You have to examine her very thoroughly. You have to be patient. You have to be very comprehensive. You have to deal with her with caution to know the usual and the common and the rare causes of the pelvic congestion. You have to encourage her to talk about her symptoms. You have to let her feel that you are sympathizing with her. This is very important, and because of the rush that we usually have in our clinics, most of us don't give the patient time to tell her story in a way. You have to take good history about the pain, effect of movement, effect of pain, did she take any medication or not. You have to ask about non-gynecological causes of pain, and you have to do a pain scoring system to see how is her pain affecting her. We have to score from 0 to 10, and the patient, when she tells you her story, you can evaluate her pain score. This is the most important symptom or sign. You have to elicit tenderness at the ovarian point, which is the line between the anterior spherical spine and the umbilicus. This is the ovarian point. When you push with that point, the patient feels pain. Many diagnostic tests, ultrasound, Doppler, laparoscopy, MRI, therapeutic tests, when you give the patient some treatment for 6 months to see if this treatment will lead to improvement. So if you're not sure what's the cause of the pain. Laparoscopy misses some cases because the laparoscopy do it in the Trendelenburg position and the pressure of the abdomen is increased, so this might mask the veins. So this is very important to sometimes put the patient in the reverse Trendelenburg and decrease the abdominal pressure a bit so as to be able to see the veins. This is how it looks, the varicosities during laparoscopy beside the ovary. And this is another way of diagnosing pelvic congestion, the venography. And ultrasound, of course, you have to take history during the examination. And this is the signs of ultrasound, the parauterine veins more than 4 millimeters, the ovarian vein diameter more than 6 millimeters. And during Valsalva maneuver, you see retrograde flow in the pelvic veins. Treatment is really, you have many diversities. I'm really happy to see this paper with the diagnostic treatment of pelvic congestion with Dr. Wasila's name on this prestigious publication. We have the symptomatic pain relieving system, relieving treatment like the, I have a minute. 1 minute exactly. Okay. Hormonal treatment like medroxyprogesterone acetate to stop the cycle, Zoladex, GnRH analogs also to stop the cycle, venoactive drugs like Dapsone, we give it for 6 months, it sometimes gives a very good relief to the symptoms. We have surgical treatment, ovarian vein ligation, hysterectomy in resistant cases, and as you've heard in the previous lectures, sclerotherapy, ovarian vein embolization, and stent therapy. Pelvic vein is very common. Accurate diagnosis is a combo of ultrasound, physical, and history. Patients with pelvic pain deserve more than just a series of standard pictures. Those that we can help are among the most grateful of our patients. I got this message on the 29th of February from one of my patients. She says that she's very thankful for me because I did her surgery to relieve her from chronic pelvic pain, and her life changed after doing that surgery. You gave me your time, which is the most thoughtful of all gift of all. Thank you very much.